why dual mobility is not a good idea. And then it'll be Dr. Skolko's job to convince you why maybe you should use it. I think we both have pretty well balanced conversations about this, I think. So let's get started. By way of disclosure, I do have relevant financial disclosures here. I haven't designed or anything to do with the dual mobility, but I get research support and consulting from companies that have dual mobility devices. The more you go to these meetings and the more you talk to people, it sure seems to be that maybe we should just be putting dual mobilities in everybody, because dislocations will then go away, right? It sounds good. The dislocation rates with dual mobility papers are excellent, but I think there's no free lunch, right? We tried the same thing in 2006 with large head metal on metals, and that was a complete disaster. We've done this multiple times in orthopedics, from even before when I was alive, doing things that maybe shouldn't have been done. So I think we need to proceed cautiously and judiciously when we're using new types of technology. But I do think that dual mobility is an important step forward, but we still need to be cautious, and I'm going to explain to you why. My concerns are cobalt and chromium levels. Now, some that applies to certain types of devices, which we'll get to. Then there's polywear. We're putting an enormous poly ball into a hip replacement. And if we have a lot of polywear like we've seen in the past, it could lead to osteolysis. We don't know. The cost of it is more expensive than most other bearing devices. In dislocations, the dislocation rate is not zero. And I can show you some pretty good data that if you use thoughtful surgical planning, thoughtful techniques, that your dislocation rates can be very low, equal to dual mobility dislocation rates without the use of dual mobility. And then intraprosthetic dislocation, which I'll show you the small ball popping out of the big ball. And we'll get to that in a second. If we look at the American Joint Replacement Registry, the percentage of dual mobility use, it's the red line at the bottom. It's on the rise. It's about 10% of all primary total hip replacement surgeries done in our country. And I would think that's pretty close to where it should be, right? I don't think it should go much more above 10% if we start thinking about the high risk situations when we think we need to use it. But also, if you look at the survivorship, and this graph is a little bit funny because it's zoomed in, it's still very high, 90%, right? About 97% survivorship of dual mobility compared to 98% survivorship of non-dual mobility type of devices. But you can see that there's clearly a statistically significant difference, and whether that 1% is meaningful to you, I think you need to decide, but 1% of a lot of patients is still a lot of patients that you could potentially avoid a revision on. But not all dual mobilities are created equally. If you look at all the literature, a lot of the literature from France is actually monoblock dual mobility, so one piece shell, and then a large head, and then a small ball. So a lot of the ones that we're starting to use in the United States now are modular type of dual mobilities. That's because we love screws. And as Dr. Ranawat used to tell us, we're addicted to modularity. And so that's not something that we can easily give up. So not all of these are created equally. You need to understand the design and the materials and the tribology of what you're putting in and why your dual mobility might be better than others in terms of that. Let's get to metal ions. As you saw there on the modular dual mobility device, you have a titanium cup. I'm going to go back for 1 second. You have a titanium cup. You're going to have a cobalt chrome liner into the titanium cup. You're going to have a large poly ball, and then hopefully a ceramic head, and then the stem, right? So there's now multiple interfaces here. And I think a lot of our metal ion concerns are going to come from this bearing surface here, where you've got the cobalt chrome liner into the titanium cup. Obviously, with a monoblock, you don't have that design. And with some of these, you actually have titanium on titanium, which may not be a problem for releasing cobalt chrome for obvious reasons. So you need to know what the design is. And when we looked at this, it's not zero, right? These patients are having actually a little bit elevation in their levels of cobalt. And we're starting to understand that you don't have to have a cobalt of 7 or 10 or 15 or 1,000 in order to have a problem with your dual mobility device or a problem with metal ions. You can have reactions to the metal ions with cobalt levels around 1. And between 0 and 1, a lot of the machines that we use to test are actually not very good at detecting levels that are below 1, but still slightly elevated. So I would send you to make sure you carefully understand the machines that you're getting your levels at, and use the same machine if you're going to track people's levels over time. In the monoblock levels, those are non-detectable for obvious reasons. There's nothing that to give corrosion or metal ions, but in the modular levels, they're not very high, but they are around 1, which could be a potential problem for metal reaction. Now, when do we see this metal reaction problem? It actually happens to be more so when you malseat the liners. We reviewed a lot of these from HSS, about 567 cases, and 5.6%, almost 6% of these were mal-seated liners. So not putting the liner perfectly flush with this particular design. Right? Other designs have different locking mechanisms that you can be certain that it's well seated, but some of them, it's a little bit harder to know if that liner is perfectly seated. And if you have a mal-seated liner, that actually could lead to micromotion, fretting, and corrosion, causing elevated metal ion levels and then hypersensitivity reactions. And we know that when you have a mal-seated liner, the fretting and corrosion was actually much higher than it was when you had a well-seated liner. And this is another paper that was presented several years ago at the Hip Society. So under physiologic loads, fretting corrosion was observed when you had a canted or mal-seated liner, which could potentially go down the road to metal reactions. They created this chamber and they put it in physiologic fluid. So a very well done, robust testing technique, and showed that the mal-seated liners had a significantly higher rate of fretting current. What about wear? You put that large poly ball in there. This was a study by Michael Meneghini, 34 dual mobility hips, and the wear rate was above actually the osteolysis threshold for at 1 year, 2 years, and at 5 years after this wearing in period. So if you have a third body, the particle in there, some cement or piece of bone, that wear could go increased. But we don't really know. We haven't seen a lot of osteolysis from wear of these. It hasn't borne out in the French data. And we haven't seen it with modern generation polyethylene. So even though this is above the osteolysis threshold, the size of the molecules, I'm not really sure that it's going to cause a lot of osteolysis because we just haven't seen it. But it's certainly a concern. What about cost? Now we did a nice cost effectiveness analysis here. It is more expensive, but the probability, it really depends on how you spin the data. If you have a dislocation rate of 8% and you can reduce it down to 1%, the cost of a dual mobility for it to be useful is about $1,000. If you want a dislocation rate of 4% and reduce that down to 0.5%, then the cost is about $500. So it really depends on what the delta is going to be in the reduction of dislocations where the cost becomes useful. Because if you have a dislocation and then you need to revise the patient because they dislocated, that's expensive. So maybe putting some money up front to prevent the dislocation will actually be beneficial. But there's no question, I think, that the dislocation rate is lower in high-risk patients with a dual mobility device than it is with standard implants, right? But it's still not zero. You can have dislocations with dual mobilities, and that's because of many factors that we may get to in the past. But I think that when they dislocate, it's a problem. These patients, although they don't dislocate very often, maybe 1% or less, when they have a dislocation and you try to reduce it, you can have an intraprosthetic dislocation. That's where the small ball is dislocated from the big ball. And that rate in Peter's study, and he's going to talk about this, I'm sure, was 71%. So we have to change the way that we approach a dislocated dual mobility. For us, these are no longer really done in the ER. These are done probably in the operating room or under very good sedation, under anesthesia, to make sure you don't have an intraprosthetic dislocation, because 71% of the time that may actually happen. And that requires you then to go and open reduce it. So it really changes, I think, the management of these patients. When they dislocate, it becomes a big problem. This is what it might look like. It looks like the hip is reduced, but it's going to be eccentric. And that's because the dual mobility liner is sitting off in the soft tissues. So very carefully analyze a post-reduction x-ray when you reduce a dual mobility to make sure you don't have that intraprosthetic dislocation. But when should you use this? We think that it's really in the high-risk patients. And the high-risk patients are those with spine fusions, neurologic problems, cognitive deficits, maybe even all hip fracture patients. Okay, you can make an argument. So we looked at this, and we're doing definitely dual mobilities in 3 or more levels of fusion. or if you have a spinal deformity with a PIL, a mismatch of greater than 10 degrees, or even if you have a large posterior pelvic tilt more than 13 degrees, those types of things are very high risk for dislocation, up to 6 or 8 or even 10%. So using a dual mobility to bring that back down to 1 or 2%, I think is reasonable, because the 10% dislocation rate in the hip replacement practice is quite extremely elevated. You need to do something differently for those patients. You want to consider it when you're doing high risk females, very, very flexible hip fractures, neurologic complications, like I said, a lot of yoga, and then maybe a stiff spine, or if they have a fusion to the sacrum. But this is a case here. It looks pretty good on a regular x-ray AP pelvis. Very simple hip arthritis. You don't see very much, but she does have a history of spine fusion. And when you get her standing AP pelvis, you can see she's got a large posterior pelvic tilt. She's got a large outlet view there. The pubis and the coccyx are overlying. This is an extremely high risk for dislocation, especially when you check on the standing lateral view. You've got a large posterior pelvic tilt. That's a big risk factor. You should clue you in. This is somebody you need to use a large head, 40 millimeters if you can on the cup size, maybe even dual mobility if you're able. That's what we did in her to prevent her from dislocating, because the dislocation rate in this exact patient is about 6 to 10%. So very, very high. We used the dual mobility. So we accepted the risks that I showed you in order to drop her dislocation rate. In conclusion, not all the designs are the same. Be very careful about which one you choose. These are very helpful in high-risk cases, but the dislocation rate is not zero. So you can't expect this to solve all the problems. And there's a potential for really big problems: corrosion, osteolysis, intraprosthetic dislocations, necessitating more return to the operating room. Thanks.